Thank you very much. All right, we're back into Talk 2. Welcome back from the break, everyone. So what we're going to continue on today is starting to look a little bit about inputs and processes of health services. Now, I've had to combine a lot of these together into one talk. So, we are just scratching the surface, but hopefully it is an introduction and to give you a little bit of a food for thought for later. So each of these is 1 week's worth of talks and seminars. So today we are going to cover formal and lay care, diseases and medical knowledge, a bit about healthcare professionals and users of healthcare. So you can see that it's going to be tight on time. But with healthcare professionals and users of healthcare, we're going to come back to a seminar tomorrow, and I have a bit of reading, which I will give to you at the end of the session, so you can go home, bedtime, reading, and have a little bit more of a think if you're interested. And then we'll come together tomorrow and have a bit of a seminar time to go deeper. So not to worry if you think, oh my God, what was that all about? It just went through so quickly. Not to worry. Okay, so inputs and processes of health services. Now, while one of the models, now we say models because it's conceptual, and it is reductionist, as all models are, to help us just to have a framework of thinking about things. And we found that in this course, the Donaldian model is really helpful to think about all the formal activities of healthcare in a way of processes, of inputs. Let's start from the beginning. Inputs, processes, and outcomes. And so what do we mean by inputs? So it is actually quite conceptually easiest to think about all the things that goes into the health services. So it could be the structure, the resources, the professions, the beds, the centers, the facilities, things that we are putting in to the health services. Then we have processes, activities. We were chatting before the start, looking at, how do we measure and evaluate good quality EMS services? Is it with processes? Is it the times it takes to get people from one place to another? Is it the outcomes? Is it survival? Processes is the activities that health services does. So it could be, how many patients do we immunize? How many operations do we do? How many sessions do we give to patients after their surgery to get them walking again, physiotherapy-wise? All these, we are assuming that doing them are good. We don't know for definite, but we know that we do them, and we measure how much we do them, and that would be a process measure. And then there is also outcomes. This is what we're all about, isn't it? Actually, everything else doesn't really matter if the outcomes aren't good. We're trying to get people to less deaths, get better, what their symptoms are, the disability, and the quality of life. But we also will increasingly know that actually we don't necessarily know these outcomes. They're very hard to measure. And perhaps that is why we resort to measuring the first two a lot. We don't know if patients are what the quality of life is, what the symptoms is. But so then we say, oh, you've had the operation. That's good. You've had it. You've had your gallbladder out. It must be good. So that those are the dynamics. But it's very helpful to think about healthcare in these kind of dimensions. The outputs, just to point out that a lot of people use outputs. It's a very economic-based term, and people talk about outputs, and outputs are a combination of processes and outcomes, mainly because the latter is so hard to define. We need to use a kind of parameter to measure how effective things are, and so people lump outputs together, and actually it's a combination usually of processes and outcomes, just to be mindful of that. Health services are also organized in different ways, as we might all know. Some of us talked about we're general practitioners, so we worked in general practice. Where would that come in? Primary care. So starting from primary care, we know we're outside of hospital. Usually the first contact of the patient has community pharmacy. used to be low technologies, and the doctor in the health facility seeing the patient, 10-minute consultation. You know, the most you could do is a blood pressure if you're lucky. If not, it's the stethoscope on the chest. You know, low technology, but it is changing. In many countries, we now, probably Japan as well, mobile imaging units, MRI scanner in a truck. So, you know, that is changing. You can have screening services mobile now. Usually, in the past at least, there's been continuity in the family. You know, you've got the traditional family doctor in Canada. It's still called the family doctor. But you see the same person, the whole generations, the entire family see that one doctor. It should be the parish doctor. You know, one town in England has one doctor and the priest, and everyone used to know he is the doctor. That's the doctor's house. It probably is the same in Japan, isn't it? I've visited some similar houses, and there's the Lord's house and the doctor's house, so it's probably similar. Domiciliary care, you know, this is vanishing, but people go attending care in people's homes. I think in low, middle-income countries that can still happen, in rural places. All that primary care. Secondary care is probably where many of us have also worked in. Hospitals, usually, bigger health facilities, basic hospital services. And then we've got the next level up, which is tertiary care. And does Japan also have tertiary care? And in England, these are specialized hospitals offering, you know, very subspecialist treatments like cancer treatments, and we know that heart attack outcomes are better if you are doing in a specialized center. Stroke outcomes are much better if you're in a hyperacute stroke unit. So some of those are very located in very centralized expertise hospitals, cancer hospitals perhaps. So we call that tertiary care. In some ways, it's very helpful to know that, you know, often in allopathic medicine, health services are organized in these levels, and helpful to know what we're talking about when we are looking at healthcare. So these are sectors, and I've described to you a little pyramid of primary care, secondary care, and tertiary care. These are the levels of formal care. So lots more people access primary care. Lots more people. Most people, first port of call with a clinician, community pharmacy, is primary care. You go there and you say, oh yeah, I need to deal with something with my blood pressure or my diabetes. So that's the first point of contact with a formal clinician. Second, so you can see that actually fewer people are in the top of the pyramid. That's how it works. However, we have this huge chunk below, which is lay care. And lay care is not talked about much, but fundamentally important, as we will come to see. What is lay care?